Hello everyone. Welcome to the Global Health Education and Innovative Learning Forum channel. Myself Yuvarajan Subramaniam. In this video session, we would like to discuss the basic facts about tuberculosis, including how tuberculosis spread, latent TB infection and TB disease, signs and symptoms of tuberculosis, risk factors of tuberculosis, exposure to tuberculosis, prevention of tuberculosis, vaccines for tuberculosis, HIV and tuberculosis co-infection, and tuberculosis diabetes. Before getting into this video session, please subscribe to this GHEIL Forum channel and share all our video links to your friends, colleagues, people who work in the development and healthcare sectors. Let us start the discussion. Global tuberculosis incidence status in 2019. Tuberculosis, also known as TB, is a major cause of ill health, one of the top 10 causes of death worldwide, and the leading cause of death from a single infectious agent. As a top infectious disease, current estimates are that TB infects nearly 2 billion people, or about 1/3 of the world population. These infected, non-disease active people are considered latent tuberculosis cases. This means that people are infected with TB bacteria, but are not yet ill or active cases. Infected people have a lifetime risk of 10% of falling ill to TB. Globally in 2019, an estimated 10 million, range 8.9 to 11.1 million, people fell ill with TB. There were 1.2 million, range 1.1 to 1.3 million, TB deaths among HIV negative people, and an additional 208,000 deaths, range 1,77,000 to 2,42,000, among HIV positive people. TB affects people of both sexes and all age groups, but the highest burden is in adult men, who accounted for 56% of all TB cases in 2019. By comparison, adult women accounted for 32% and children for 12%. Among all TB cases, 8.2% were among people living with HIV. Geographically, in 2019, most TB cases were in the World Health Organization, in short, WHO, regions of Southeast Asia, 44%, Africa, 25%, and the Western Pacific, 18%, with smaller shares in the Eastern Mediterranean, 8.2%, the Americas, 2.9%, and Europe, 2.5%. 8 countries accounted for 2/3 of the global total: India, 26%, Indonesia, 8.5%, China, 8.4%, the Philippines, 6.0%, Pakistan, 5.7%, Nigeria, 4.4%, Bangladesh, 3.6%, and South Africa, 3.6%. Global targets and milestones for reductions in TB incidence and TB deaths have been set as part of the Sustainable Development Goals, in short SDGs, and WHO's End TB strategy. SDG includes a target to end the global TB epidemic by 2030. The End TB strategy includes targets of a 90% reduction in TB deaths and an 80% reduction in the TB incidence rate, new and relapse cases per 1 lakh population per year, between 2015 and 2030. The 2020 milestones are reductions of 35% and 20%, respectively. Globally, the burden of multidrug-resistant TB, in short MDR-TB, or rifampicin-resistant TB, in short RRTB, as a share of the number of TB cases remains stable. In 2019, an estimated 3.3% of new TB cases and 18% of previously treated cases had multidrug-resistant TB, rifampicin-resistant TB. In absolute numbers, there were an estimated 4,65,000 range, 4 lakhs to 5,35,000 incident cases of rifampicin-resistant TB. 78% had multidrug-resistant TB. India, 27%, China, 14%, and the Russian Federation, 8%, had the largest share of the global burden. Basic tuberculosis facts. Facts. Tuberculosis is an infectious disease usually caused by Mycobacterium tuberculosis, in short, MTB, bacteria. Tuberculosis generally affects the lungs, but can also affect other parts of the body. Most infections show no symptoms, in which case it is known as latent tuberculosis. About 10% of latent infections progress to active disease which, if left untreated, kills about half of those affected. Typical symptoms of active TB are a chronic cough with blood-containing mucus, fever, night sweats, and weight loss. It was historically called consumption due to weight loss. Infection of other organs can cause a wide range of symptoms. TB is spread from one person to the next through the air when people who have active TB in their lungs cough, spit, speak, or sneeze. People with latent TB do not spread the disease. Active infection occurs more often in people with HIV/AIDS and in those who smoke. Diagnosis of active TB is based on chest X-rays, as well as microscopic examination and culture of body fluids. Diagnosis of latent TB relies on the tuberculin skin test, in short, TST, or blood tests. Prevention of TB involves screening those at high risk, early detection and treatment of cases, and vaccination with the Bacillus calmette-guerin, in short, BCG, vaccine. Those at high risk include household, workplace, and social contacts of people with active TB. Treatment requires the use of multiple antibiotics over a long period. Antibiotic resistance is a growing problem with increasing rates of multiple drug-resistant tuberculosis. As of 2020, more than 1/4 of the world's population is thought to have a latent infection with TB. New infections occur in about 2% of the population each year. In 2020, there were more than 10 million cases of active TB which resulted in 1.5 million deaths. This makes it the number one cause of death from an infectious disease. As of 2018, most TB cases occurred in the regions of Southeast Asia, 44%, Africa, 24%, and the Western Pacific, 18%, with more than 50% of cases being diagnosed in 8 countries: India, 27%, China, 9%, Indonesia, 8%, the Philippines, 6%, Pakistan, 6%, Nigeria, 4%, and Bangladesh, 4%. The number of new cases each year has decreased since 2000. About 80% of people in many Asian and African countries test positive, while 5 to 10% of people in the United States population test positive by the tuberculin test. Tuberculosis has been present in humans since ancient times. How tuberculosis spreads. TB bacteria are spread through the air from one person to another. The TB bacteria are put into the air when a person with TB disease of the lungs or throat coughs, speaks or sings. People nearby may breathe in these bacteria and become infected. TB is not spread by shaking someone's hand, sharing food or drink, touching bed linens or toilet seats, sharing toothbrushes, or kissing. When a person breathes in TB bacteria, the bacteria can settle in the lungs and begin to grow. From there, they can move through the blood to other parts of the body, such as the kidney, spine, and brain. TB disease in the lungs or throat can be infectious. This means that the bacteria can be spread to other people. TB in other parts of the body, such as the kidney or spine, is usually not infectious. People with TB disease are most likely to spread it to people they spend time with every day. This includes family members, friends, and co-workers, or schoolmates. Individuals who are exposed to TB often do not feel sick or present any symptoms. These individuals are not contagious at this point unless their infection persists into active TB disease. At this point, the bacterium can be spread through microscopic droplets as the patient sneezes, coughs, talks, or otherwise projects contaminated sputum saliva from their body. People nearby may breathe in these bacteria and become infected as the bacteria can stay in the air for several hours. Latent TB infection and TB disease. Not everyone infected with TB bacteria becomes sick. As a result, two TB-related conditions exist: latent TB infection and TB disease. Latent TB infection, TB bacteria can live in the body without making you sick. This is called latent TB infection. In most people who breathe in TB bacteria and become infected, the body can fight the bacteria to stop them from growing. People with latent TB infection have no symptoms, don't feel sick, can't spread TB bacteria to others, usually have a positive TB skin test reaction or positive TB blood test, may develop TB disease if they do not receive treatment for latent TB infection. Many people who have latent TB infection never develop TB disease. In these people, the TB bacteria remain inactive for a lifetime without causing disease. But in other people, especially people who have a weak immune system, the bacteria become active, multiply, and cause TB disease. TB disease. TB bacteria become active if the immune system can't stop them from growing. When TB bacteria are active, multiplying in your body, this is called TB disease. People with TB disease are sick. They may also be able to spread the bacteria to people they spend time with every day. Many people who have latent TB infection never develop TB disease. Some people develop TB disease soon after becoming infected, within weeks, before their immune system can fight the TB bacteria. Other people may get sick years later when their immune system becomes weak for another reason. For people whose immune systems are weak, especially those with HIV infection, the risk of developing TB disease is much higher than for people with normal immune systems. Signs and symptoms. Symptoms of TB disease depend on where in the body the TB bacteria are growing. TB bacteria usually grow in the lungs, pulmonary TB. TB disease in the lungs may cause symptoms such as A. A bad cough that lasts 3 weeks or longer, B. Pain in the chest, and C. Coughing up blood or sputum, phlegm from deep inside the lungs. Other symptoms of TB disease are weakness or fatigue, weight loss, no appetite, chills, fever, and sweating at night. Symptoms of TB disease in other parts of the body depend on the area affected. People who have latent TB infection do not feel sick, do not have any symptoms, and cannot spread TB to others. Tuberculosis may infect any part of the body, but most commonly occurs in the lungs, known as pulmonary tuberculosis. Extrapulmonary TB occurs when tuberculosis develops outside of the lungs, although extrapulmonary TB may coexist with pulmonary TB. General signs and symptoms include fever, chills, night sweats, loss of appetite, weight loss, and fatigue. Significant nail clubbing may also occur. Clinical manifestation of tuberculosis. TB is classified mainly into two groups as pulmonary tuberculosis, in short PTB, and extrapulmonary tuberculosis, in short EPTB. Pulmonary TB is further classified into subgroups such as primary pulmonary disease, post-primary pulmonary disease, adult type, and miliary TB. Similarly, extrapulmonary TB is further classified into subgroups such as lymph node TB, lymphadenitis, pleural TB, TB of upper airways, genitorinary TB, skeletal TB, Tuberculosis Meningitis and tuberculoma, gastrointestinal TB, pericardial TB, tuberculous pericarditis, HIV-associated TB, and less common extrapulmonary forms. Pulmonary tuberculosis. If a tuberculosis infection does become active, it most commonly involves the lungs, in about 90% of cases. Symptoms may include chest pain and a prolonged cough producing sputum. About 25% of people may not have any symptoms, that is, they remain asymptomatic. Occasionally, people may cough up blood in small amounts, and in very rare cases, the infection may erode into the pulmonary artery or a Rasmussen's aneurysm, resulting in massive bleeding. Tuberculosis may become a chronic illness and cause extensive scarring in the upper lobes of the lungs. The upper lung lobes are more frequently affected by tuberculosis than the lower ones. The reason for this difference is not clear. It may be due to either better airflow or poor lymph drainage within the upper lungs. Primary pulmonary disease. Primary TB refers to the infection of a previously uninfected, tuberculin-negative individual. A few patients develop a self-limiting febrile illness, but clinical disease only occurs if there is a hypersensitivity reaction or progressive infection. The progressive primary disease may appear during the initial illness or after a latent period of weeks or months. Post-primary pulmonary disease, adult type. Also referred adult type TB, refers to exogenous, new, infection, or endogenous, reactivation of a dormant primary lesion, infection in a person who has been sensitized by earlier exposure. It is most frequently pulmonary and characteristically occurs in the apex of an upper lobe, where the oxygen tension favors survival of the strictly aerobic organism. The onset is usually insidious, developing slowly over several weeks. Systemic symptoms include fever, night sweats, malaise, and loss of appetite and weight, and are accompanied by progressive pulmonary symptoms. In extensive disease, collapse may be marked and results in significant displacement of the trachea and mediastinum. Occasionally, a caseous lymph node may drain into an adjoining bronchus, leading to tuberculous pneumonia. Miliary TB. Bloodborne dissemination gives rise to miliary Tb, which may present acutely but more frequently is characterized by 2 to 3 weeks of fever, night sweats, anorexia, weight loss, and a dry cough. Hepatosplenomegaly may develop, and the presence of a headache may indicate coexistent tuberculous meningitis. Auscultation of the chest is frequently normal, but in more advanced diseases, widespread crackles are evident. Fundoscopy may show choroidal tubercles. The classical appearances on chest X-ray are of fine 1 to 2 mm lesions, millet seed, distributed throughout the lung fields, although occasionally the appearances are coarser. Anemia and leukopenia reflect bone marrow involvement. Cryptic Miliary Tb is an unusual presentation sometimes seen in old age. Extrapulmonary tuberculosis. In 15 to 20% of active cases, the infection spreads outside the lungs, causing other kinds of TB. These are collectively denoted as extrapulmonary tuberculosis. Extrapulmonary TB occurs more commonly in people with a weakened immune system and young children. In those with HIV, this occurs in more than 50% of cases. Notable extrapulmonary infection sites include the pleura, in tuberculous pleurisy, the central nervous system, in tuberculous meningitis, the lymphatic system, in scrofula of the neck, the genitorinary system, in urogenital tuberculosis, and the bones and joints, in port disease of the spine, among others. A potentially more serious, widespread form of TB is called disseminated tuberculosis. It is also known as miliary tuberculosis. Miliary TB currently makes up about 10% of extrapulmonary cases. Extrapulmonary sites most commonly involved in TB are the lymph nodes, pleura, genitorinary tract, bones and joints, meninges, peritoneum, and pericardium. However, virtually all organ systems may be affected. As a result of hematogenous dissemination in HIV-infected individuals, extrapulmonary TB is seen more commonly today than in the past. Extrapulmonary tuberculosis accounts for about 20% of cases in those who are HIV negative but is more common in HIV positive individuals. Lymph node tuberculosis, lymphadenitis, once caused mainly by Mycobacterium bovis. Tuberculous lymphadenitis is today due largely to Mycobacterium tuberculosis. Lymph nodes are the most common extrapulmonary site of disease. Cervical and mediastinal glands are affected most frequently, followed by axillary and inguinal, and more than one region may be involved. The disease may represent primary infection, spread from contiguous sites, or reactivation. Supraclavicular lymphadenopathy is often the result of the spread of mediastinal disease. The nodes are usually painless and initially mobile but become matted together with time. When caseation and liquefaction occur, the swelling becomes fluctuant and may discharge through the skin with the formation of a collar's tongue abscess and sinus formation. The tuberculin test is usually strongly positive. During or after treatment, paradoxical enlargement, development of new nodes, and suppuration may all occur but without evidence of continued infection. Surgical excision is rarely necessary. Plural tuberculosis. Involvement of the pleura accounts for 20% of extrapulmonary cases. Isolated pleural effusion usually reflects recent primary infection, and the collection of fluid in the pleural space represents a hypersensitivity response to mycobacterial antigens. The pleural disease may also result from the contiguous parenchymal spread, as in many cases of pleurisy accompanying post-primary disease. Depending on the extent of reactivity, the effusion may be small, remain unnoticed, and resolve spontaneously, or may be sufficiently large to cause symptoms such as fever, pleuritic chest pain, and dyspnea. Physical findings are those of pleural effusion, dullness to percussion, and absence of breath sounds. A chest radiograph reveals the effusion and, in up to 1/3 of cases, also shows a parenchymal lesion. The pleural fluid is purulent and thick and contains large numbers of lymphocytes. Acid-fast smears and mycobacterial cultures are often positive. Surgical drainage is usually required as an adjunct to chemotherapy. Tuberculous empyema may result in severe pleural fibrosis and restrictive lung disease. Removal of the thickened visceral pleura, decortication, is occasionally necessary to improve lung function. Tuberculosis of upper airways, TB of the upper airways, may involve the larynx, pharynx, and epiglottis. Symptoms include hoarseness, dysphonia, and dysphagia in addition to chronic productive cough. Findings depend on the site of involvement, and ulcerations may be seen on laryngoscopy. The acid-fast smear of the sputum is often positive, but a biopsy may be necessary in some cases to establish the diagnosis. Genitorinary tuberculosis, genitorinary TB, which accounts for 10 to 15% of all extrapulmonary cases, may involve any portion of the genitorinary tract. Local symptoms predominate. Fever and night sweats are rare with renal tract TB, and patients are often only mildly symptomatic for many years. Hematuria, frequency, and dysuria are often present, with sterile pyuria found on urine microscopy and culture. Genital TB is diagnosed more commonly in females than in male patients. In women, infertility from endometritis, or pelvic pain, and swelling from salpingitis or a tubo-ovarian abscess occurs occasionally. In men, genitorinary TB may present as epididymitis or prostatitis. Genitorinary TB responds well to chemotherapy. Skeletal tuberculosis, TB of the bones and joints, is responsible for 10% of extrapulmonary cases. The spine is the most common site for bony TB, like Pott's disease, which usually presents with chronic back pain and typically involves the lower thoracic and lumbar spine. The infection starts as a discitis and then spreads along the spinal ligaments to involve the adjacent anterior vertebral bodies, causing angulation of the vertebrae with subsequent kyphosis. Perivertebral and psoas abscess formation is common, and the disease may present with a large, cold abscess in the inguinal region. The major differential diagnosis is malignancy, which tends to affect the vertebral body and leave the disc intact. Important complications include spinal instability or cord compression. TB can affect any joint but most frequently involves the hip or knee. Presentation is usually insidious, with pain and swelling. Fever and night sweats are uncommon. Radiological changes are often non-specific, but, as the disease progresses, reduction in joint space and erosions appear. Ponsets arthropathy is an immunologically mediated polyarthritis that usually resolves within 2 months of starting treatment. Tuberculosis meningitis and tuberculoma, TB of the central nervous system, accounts for 5% of extrapulmonary cases. It is seen most often in young children but also develops in adults, especially those infected with HIV. Tuberculosis meningitis results from the hematogenous spread of primary or post-primary pulmonary TB or the rupture of a subependymal tubercle into the subarachnoid space. The disease often presents subtly as headache and slight mental changes after a prodrome of weeks of low-grade fever, malaise, anorexia, and irritability. Typically, the disease evolves over 1 to 2 weeks, a course longer than that of bacterial meningitis. Since meningeal involvement is pronounced at the base of the brain, paresis of cranial nerves, ocular nerves in particular, is a frequent finding, and the involvement of cerebral arteries may produce focal ischemia. The ultimate evolution is toward coma, with hydrocephalus and intracranial hypertension. Tuberculoma, an uncommon manifestation of central nervous system TB, presents as one or more space-occupying lesions and usually causes seizures and focal signs. Gastrointestinal tuberculosis, gastrointestinal TB is uncommon, making up 3.5% of extrapulmonary cases. TB can affect any part of the bowel, and patients may present with a wide range of symptoms and signs. Various pathogenetic mechanisms are involved: swallowing of sputum with direct seeding, hematogenous spread, ingestion of milk from cows affected by bovine TB. Although any portion of the gastrointestinal tract may be affected, the terminal ileum and the caecum are the sites most commonly involved. Fever, night sweats, anorexia, and weight loss are usually prominent, and a right iliac fossa mass may be palpable. Ultrasound or CT may reveal thickened bowel wall, abdominal lymphadenopathy, mesenteric thickening, or ascites. Barium enema and small bowel enema reveal narrowing, shortening, and distortion of the bowel, with cecal involvement predominating. Diagnosis rests on obtaining histology by either colonoscopy or mini laparotomy. The main differential diagnosis is Crohn's disease. Pericardial tuberculosis, tuberculous pericarditis due either to direct extension from adjacent mediastinal or hilar lymph nodes or to hematogenous spread. Pericardial TB has often been a disease of the elderly. The disease occurs in 2 pericardial effusions and constrictive pericarditis. Fever and night sweats are rarely prominent, and the presentation is usually insidious, with breathlessness and abdominal swelling. Coexistent pulmonary disease is very rare, except for pleural effusion. Pulsus paradoxus, hepatomegaly, prominent ascites, and peripheral edema are common to both types. Pericardial effusion is associated with increased pericardial dullness and a globular enlarged heart on chest X-ray, and pericardial calcification occurs in around 25% of cases. Constriction is associated with an early third heart sound and, occasionally, atrial fibrillation. Diagnosis is based on the clinical, radiological, and echocardiographic. The effusion is frequently blood-stained. The open pericardial biopsy can be performed where there is diagnostic uncertainty. The addition of corticosteroids to anti-tuberculosis treatment has been shown to help both forms of pericardial disease. HIV-associated tuberculosis, TB can appear at any stage of HIV infection, and its presentation varies with the stage. When CMI is only partially compromised, pulmonary TB presents in a typical manner with the pallor infiltrates and cavitation and without significant lymphadenopathy or pleural effusion. In the late stages of HIV infection, a primary TB-like pattern, with diffuse interstitial or miliary infiltrates, little or no cavitation, and intrathoracic lymphadenopathy is more common. Extrapulmonary TB is common among HIV-infected patients. The most common forms are lymphatic, disseminated, pleural, and pericardial. Mycobacteria and meningitis are also frequent, particularly in advanced HIV disease. Less common extrapulmonary forms. Tuberculosis otitis is rare and presents as hearing loss, otorrhea, and tympanic membrane perforation. In the nasopharynx, TB may simulate granulomatosis with polyangiitis, like vaginas. Cutaneous manifestations of TB include primary infection due to direct inoculation, abscesses and chronic ulcers, scrofulodema, lupus vulgaris, a smoldering disease with nodules, plaques, and fissures, miliary lesions, and erythema nodosum. Tuberculous mastitis results from the retrograde lymphatic spread, often from the axillary lymph nodes. Adrenal TB is a manifestation of disseminated disease presenting rarely as adrenal insufficiency. Congenital TB results from the transplacental spread of tubercle bacilli to the fetus or from ingestion of contaminated amniotic fluid. This rare disease affects the liver, spleen, lymph nodes, and various other organs. Causes, transmission, and risk of transmission. Mycobacteria. The main cause of TB is Mycobacterium tuberculosis, MTB, a small, aerobic, non-motile bacillus. The high lipid content of this pathogen accounts for many of its unique clinical characteristics. It divides every 16 to 20 hours, which is an extremely slow rate compared with other bacteria, which usually divide in less than an hour. Mycobacteria have an outer membrane lipid bilayer. If a gram stain is performed, MTB either stains very weakly, gram-positive, or does not retain dye as a result of the high lipid and mycolic acid content of its cell wall. MTB can withstand weak disinfectants and survive in a dry state for weeks. In nature, the bacterium can grow only within the cells of a host organism, but M. tuberculosis can be cultured in the laboratory. Using histological stains on expectorated samples from phlegm, also called sputum, scientists can identify MTB under a microscope. Since MTB retains certain stains even after being treated with an acidic solution, it is classified as an acid-fast bacillus. The most common acid-fast staining techniques are the GHEIL stain and the quinoone stain, which dye acid-fast bacilli a bright red that stands out against a blue background. Oraminrhodamine staining and fluorescence microscopy are also used. The Mycobacterium tuberculosis complex, MTBC, includes 4 other TB-causing mycobacteria: Mycobacterium bovis, Mycobacterium africanum, Mycobacterium caineti, and Mycobacterium microti. Mycobacterium africanum is not widespread, but it is a significant cause of tuberculosis in parts of Africa. Mycobacterium bovis was once the common cause of tuberculosis, but the introduction of pasteurized milk has almost eliminated this as a public health problem in developed countries. Mycobacterium caineti is rare and seems to be limited to the Horn of Africa, although a few cases have been seen in African immigrants. Mycobacterium microti is also rare and is seen almost only in immunodeficient people, although its prevalence may be significantly underestimated. Other known pathogenic mycobacteria include Mycobacterium lepri, Mycobacterium avium, and Mycobacterium kansasi. The latter 2 species are classified as non-tuberculous mycobacteria, NTM. Non-tuberculous mycobacteria cause neither TB nor leprosy, but they do cause lung diseases that resemble TB. Transmission. When people with active pulmonary TB cough, sneeze, speak, sing, or spit, they expel infectious aerosol droplets 0.5 to 5.0 m in diameter. A single sneeze can release up to 40,000 droplets. Each one of these droplets may transmit the disease. Since the infectious dose of tuberculosis is very small, the inhalation of fewer than 10 bacteria may cause an infection. Risk of transmission. People with prolonged, frequent, or close contact with people with TB are at particularly high risk of becoming infected, with an estimated 22% infection rate. A person with active but untreated tuberculosis may infect 10 to 15 or more other people per year. Transmission should occur from only people with active TB. Those with latent infection are not thought to be contagious. The probability of transmission from one person to another depends upon several factors, including the number of infectious droplets expelled by the carrier, the effectiveness of ventilation, the duration of exposure, the virulence of the Mycobacterium tuberculosis strain, the level of immunity in the uninfected person, and others. The cascade of person-to-person spread can be circumvented by segregating those with active, overt TB and putting them on anti-TB drug regimens. After about 2 weeks of effective treatment, subjects with non-resistant active infections generally do not remain contagious to others. If someone does become infected, it typically takes 3 to 4 weeks before the newly infected person becomes infectious enough to transmit the disease to others. Risk factors for tuberculosis. Some people develop TB disease soon after becoming infected, within weeks, before their immune system can fight the TB bacteria. Other people may get sick years later when their immune system becomes weak for another reason. Overall, about 5 to 10% of infected persons who do not receive treatment for latent TB infection will develop TB disease at some time in their lives. For persons whose immune systems are weak, especially those with HIV infection, the risk of developing TB disease is much higher than for persons with normal immune systems. Generally, persons at high risk for developing TB disease fall into 2 categories. Persons who have been recently infected with TB bacteria, and persons with medical conditions that weaken the immune system. High risk for developing tuberculosis disease. Persons who have been recently infected with TB bacteria. This includes close contacts of a person with infectious TB disease. Persons who have immigrated from areas of the world with high rates of TB. Children less than 5 years of age who have a positive TB test. Groups with high rates of TB transmission, such as homeless persons, injection drug users, and persons with HIV infection. Persons who work or reside with people who are at high risk for TB in facilities or institutions such as hospitals, homeless shelters, correctional facilities, nursing homes, and residential homes for those with HIV. Persons with medical conditions that weaken the immune system. Babies and young children often have weak immune systems. Other people can have weak immune systems, too, especially people with any of these conditions. HIV infection, the virus that causes AIDS. Substance abuse. Silicosis. Diabetes mellitus. Severe kidney disease. Low body weight. Organ transplants. Head and neck cancer. Medical treatments such as corticosteroids or organ transplant. Specialized treatment for rheumatoid arthritis or Crohn's disease. Several factors make individuals more susceptible to TB infection and/or disease. Active disease risk. The most important risk factor globally for developing active TB is concurrent HIV infection, 13% of those with TB are also infected with HIV. This is a particular problem in sub-Saharan Africa, where HIV infection rates are high. Of those without HIV infection who are infected with tuberculosis, about 5 to 10% develop active disease during their lifetimes. In contrast, 30% of those co-infected with HIV develop active disease. The use of certain medications, such as corticosteroids and infliximab, an anti-TNF monoclonal antibody, is another important risk factor, especially in the developed world. Other risk factors include alcoholism, diabetes mellitus, 3-fold increased risk, silicosis, 30-fold increased risk, tobacco smoking, 2-fold increased risk, indoor air pollution, malnutrition, young age, recently acquired TB infection, recreational drug use, severe kidney disease, low body weight, organ transplant, head and neck cancer, and genetic susceptibility. The overall importance of genetic risk factors remains undefined. Infection susceptibility. Tobacco smoking increases the risk of infections, in addition to increasing the risk of active disease and death. Additional factors increasing infection susceptibility include young age. There are several risk factors for tuberculosis infection. Worldwide, the most important of these is HIV. Co-infection with HIV is a particular problem in sub-Saharan Africa, due to the high incidence of HIV in these countries. Smoking more than 20 cigarettes a day increases the risk of TB by 2 to 4 times, while silicosis increases the risk of 30-folds. Diabetes mellitus is also an important risk factor that is growing in importance in developing countries. Other disease states that increase the risk of developing tuberculosis are Hodgkin lymphoma, end-stage renal disease, chronic lung disease, malnutrition, and alcoholism. A person's genetics also play a role. Silicosis. People with silicosis have an approximately 30-fold greater risk for developing TB. Silica particles irritate the respiratory system, causing immunogenic responses such as phagocytosis, which results in high lymphatic vessel deposits. It is probably this interference and blockage of macrophage function that increases the risk of tuberculosis. Persons with chronic kidney failure and also on hemodialysis have an increased risk. Given that silicosis greatly increases the risk of tuberculosis, more research about the effect of various indoor or outdoor air pollutants on the disease would be necessary. Some possible indoor sources of silica include paint, concrete, and Portland cement. Crystalline silica is found in concrete, masonry, sandstone, rock, paint, and other abrasives. The cutting, bricking, crushing, drilling, grinding, or abrasive blasting of these materials may produce fine silica dust. It can also be in soil, mortar, plaster, and shingles. Some drugs, including rheumatoid arthritis drugs that work by blocking tumor necrosis factor alpha, an inflammation-causing cytokine, raise the risk of activating a latent infection due to the importance of this cytokine in the immune defense against TB. HIV. HIV is a major risk factor for tuberculosis. The risk of developing TB is estimated to be between 20 to 37 times greater in people living with HIV than among those without HIV infection. TB is a leading cause of morbidity and mortality among people living with HIV. In 2009, there were 9.4 million new cases of TB, of which 13% million were among people living with HIV. Of the 1.7 million people who died of TB, 4 24% were living with HIV. Nutrition. Low body weight is associated with the risk of tuberculosis. A body mass index, BMI, below 18.5 increases the risk by 2 to 3 times. An increase in body weight lowers the risk. People with diabetes mellitus are at increased risk of contracting tuberculosis, and they have a poorer response to treatment, possibly due to poorer drug absorption. Other clinical conditions that have been associated with active TB include gastrectomy with attendant weight loss and malabsorption, jejunal bypass, renal and cardiac transplantation, carcinoma of the head or neck, and other neoplasms, example, lung cancer, lymphoma, and leukemia. Diet may also modulate risk. For example, among immigrants in London from the Indian subcontinent, vegetarian Hindu Asians were found to have an 8.5-fold increased risk of tuberculosis compared to Muslims who ate meat and fish daily. Although a causal link is not proved by this data, this increased risk could be caused by micronutrient deficiencies, possibly iron, vitamin B12 or vitamin D. Further studies have provided more evidence of a link between vitamin D deficiency and an increased risk of contracting tuberculosis. Globally, the severe malnutrition common in parts of the developing world causes a large increase in the risk of developing active tuberculosis due to its damaging effects on the immune system. Along with overcrowding, poor nutrition may contribute to the strong link observed between tuberculosis and poverty. Crowding. Prisoners are particularly vulnerable to infectious diseases such as HIV/AIDS and TB. Imprisonment facilities provide conditions that allow TB to spread rapidly due to overcrowding, poor nutrition, and a lack of health services. TB outbreaks have been reported in prisons and jails throughout the world and are particularly concerning in the United States, which incarcerates a larger proportion of its population than any other nation. The prevalence of TB in prisons is much higher than among the general population, in some countries as much as 40 times higher. Diabetes mellitus. There is also a very high 3-fold increased risk of infection with TB for patients who have diabetes mellitus. Higher associations have been found between diabetes mellitus and TB in study populations from Central America, Europe, and Asia. Developing countries with exponential economic growth such as India and China that account for 40% of incident TB cases in 2010 and are estimated to have a 69% increase in people with diabetes mellitus are of concern for the joint burden of disease between diabetes mellitus and tuberculosis. The correlation between diabetes mellitus and TB concerns public health as it merges communicable and non-communicable diseases. Also, TB is associated with poor treatment outcomes in diabetics. Other conditions that increase risk include the sharing of needles among 4 drug users, recent TB infection or a history of inadequately treated TB, chest X-ray suggestive of previous TB, showing fibrotic lesions and nodules, prolonged corticosteroid therapy and other immunosuppressive therapy, compromised immune system. 30–40% of people with AIDS worldwide also have TB, hematologic and reticuloendothelial diseases, such as leukemia and Hodgkin's disease, end-stage kidney disease, intestinal bypass, chronic malabsorption syndromes, vitamin D deficiency, and low body weight. There is also genetic susceptibility. Exposure to tuberculosis. What to do if you have been exposed to TB? You may have been exposed to TB bacteria if you spent time near someone with TB disease. The TB bacteria are put into the air when a person with active TB disease of the lungs or throat coughs, sneezes, speaks, or sings. You cannot get TB from clothes, drinking glass, eating utensils, handshakes, toilets, and other surfaces. If you think you have been exposed to someone with TB disease, you should contact your doctor or local health department about getting a TB skin test or a special TB blood test. Be sure to tell the doctor or nurse when you spend time with the person who has TB disease. It is important to know that a person who is exposed to TB bacteria is not able to spread the bacteria to other people right away. Only persons with active TB disease can spread TB bacteria to others. Before you would be able to spread TB to others, you would have to breathe in TB bacteria and become infected. Then the active bacteria would have to multiply in your body and cause active TB disease. At this point, you could spread TB bacteria to others. People with TB disease are most likely to spread the bacteria to people they spend time with every day, such as family members, friends, co-workers, or schoolmates. Some people develop TB disease soon, within weeks, after becoming infected before their immune system can fight the TB bacteria. Other people may get sick years later when their immune system becomes weak for another reason. Many people with TB infection never develop TB disease. Prevention of tuberculosis. Preventing latent TB infection from progressing to TB disease. Many people who have latent TB infection never develop TB disease. But some people who have latent TB infection are more likely to develop TB disease than others. Those at high risk for developing TB disease include people with HIV infection, people who became infected with TB bacteria in the last 2 years, babies and young children, people who inject illegal drugs, people who are sick with other diseases that weaken the immune system, elderly people, and people who were not treated correctly for TB in the past. If you have latent TB infection and you are in one of these high-risk groups, you should take medicine to keep from developing TB disease. There are several treatment options for latent TB infection. You and your healthcare provider must decide which treatment is best for you. If you take your medicine as instructed, it can keep you from developing TB disease. Because there are fewer bacteria, treatment for latent TB infection is much easier than treatment for TB disease. A person with TB disease has a large amount of TB bacteria in the body. Several drugs are needed to treat TB disease. Tuberculosis vaccines. Tuberculosis, TB, vaccines are vaccinations intended for the prevention of tuberculosis. Immunotherapy as a defense against TB was first proposed in 1890 by Robert Koch. Today, the only effective tuberculosis vaccine in common use is Bacillicomethurine, BCG, first used on humans in 1921. About 3 out of every 10,000 people who get the vaccine experience side effects, which are usually minor except in severely immunodepressed individuals. While BCG immunization provides fairly effective protection for infants and young children, including defense against TB meningitis and miliary TB, its efficacy in adults is variable, ranging from 0% to 80%. Several variables have been considered responsible for the varying outcomes. Demand for TB immunotherapy advancement exists because the disease has become increasingly drug resistant. Other tuberculosis vaccines are at various stages of development, including 1. MVA-85A, 2. RBCG30, and 3. 72F fusion protein. Tuberculosis and HIV co-infection. The co-epidemic of tuberculosis, TB, and human immunodeficiency virus, HIV, is one of the major global health challenges in the present time. The World Health Organization, WHO, reports 9.2 million new cases of TB in 2006, of whom 7.7% were HIV infected. Tuberculosis is the most common contagious infection in HIV immunocompromised patients, leading to death. These diseases act in combination as HIV drives a decline in immunity while tuberculosis progresses due to defective immune status. This condition becomes more severe in the case of multi-drug, MDR-TB, and extensively drug-resistant TB, XDR-TB, which are difficult to treat and contribute to increased mortality. Tuberculosis can occur at any stage of HIV infection. The risk and severity of tuberculosis increased soon after infection with HIV. A study on gold miners of South Africa revealed that the risk of TB was doubled during the first year after HIV seroconversion. Although tuberculosis can be a relatively early manifestation of HIV infection, it is important to note that the risk of tuberculosis progresses as the CD4 cell count decreases along with the progression of HIV infection. The risk of TB generally remains high in HIV-infected patients, remaining above the background risk of the general population even with effective immune reconstitution and high CD4 cell counts with antiretroviral therapy. HIV-TB infection is a bidirectional interaction of the two pathogens. TB disease appears when the immune response is unable to stop the growth of Mycobacteria. The cytokine IFN-gamma plays a pivotal role in the signaling of the immune system during infection. Reduced production of IFN-gamma or its cellular receptors leads to severe and fatal TB. During HIV infection, IFN-gamma production is decreased dramatically, which leads to an increased risk of developing reactivation or reinfection by M. tuberculosis in these HIV-TB patients. TB may also influence HIV evolution. Pro-inflammatory cytokine production by tuberculous granulomas, in particular TNF, has been associated with increased HIV viremia, which might accelerate the course of the disease. The risk of death in HIV-TB infected patients is twice that of HIV-infected patients without TB, with most deaths caused by progressive HIV infection, rather than TB. Tuberculosis is a serious health threat, especially for people living with HIV. People living with HIV are more likely than others to become sick with TB. Worldwide, TB is one of the leading causes of death among people living with HIV. Without treatment, as with other opportunistic infections, HIV and TB can work together to shorten lifespan. Someone with untreated latent TB infection and HIV infection is much more likely to develop TB disease during his or her lifetime than someone without HIV infection. Among people with latent TB infection, HIV infection is the strongest known risk factor for progressing to TB disease. A person who has both HIV infection and TB disease has an AIDS-defining condition. People infected with HIV who also have either latent TB infection or TB disease can be effectively treated. The first step is to ensure that people living with HIV are tested for TB infection. If found to have TB infection, further tests are needed to rule out TB disease. The next step is to start treatment for latent TB infection or TB disease based on test results. Treatment. Untreated latent TB infection can quickly progress to TB disease in people living with HIV since the immune system is already weakened. And without treatment, TB disease can progress from sickness to death. Fortunately, there are several treatment options for people living with HIV who also have either latent TB infection or TB disease. Tuberculosis and diabetes mellitus. Diabetes is a chronic, long-lasting disease that affects how the body turns food into energy. Tuberculosis, TB, is a serious health threat, especially for people living with diabetes. Two TB-related conditions exist: latent TB infection and TB disease. People with latent TB infection are not sick because the body can fight the bacteria to stop them from growing. People with TB disease are sick and have active TB because the body cannot stop the bacteria from growing. People living with diabetes who are also infected with TB are more likely to develop TB disease and become sick with TB. Someone with untreated latent TB infection and diabetes is more likely to develop TB disease than someone without diabetes. Without proper treatment, diabetes and TB can increase health complications. Treatment. Untreated latent TB infection can progress to TB disease. TB disease, without treatment, can progress from sickness to death. Fortunately, treatment options are available for people with diabetes who also have either latent TB infection or TB disease. If a person is diagnosed with TB infection, further testing is required to rule out TB disease. People with either latent TB infection or TB disease can be effectively treated. Before beginning treatment for TB disease or latent TB infection, TB patients should talk to their doctor about any other medication they are taking, including medicine for diabetes. Some medications used to treat TB might interact with medications used to treat diabetes. I hope this video will be extremely useful and thank you so much for watching this video. Kindly click the like button in case you feel useful and give your valuable comments for better improvement. Please subscribe GHEIL Forum channel and share all our video links to your friends, colleagues, people who work in the development and healthcare sectors. Once again, thank you so much.